Dear friends, colleagues, and students, good afternoon. On behalf of the panelists, I would like to thank everyone for making the time to attend this webinar. This webinar is organized by Alice Lee Center for Nursing Studies, National University of Singapore. I'm Wenru, Associate Professor from NUS Nursing. I'm the moderator for this webinar. First of all, I would like to invite Prof. Emily Ong, Head of Department, to make an opening speech. Prof. Emily, please.
A very warm welcome to our webinar. I'm delighted to share that the response to this webinar has been very overwhelming. Thank you for your support. I'd like to introduce briefly our department to all the participants. Our department is known as the Alice Lee Center for Nursing Studies. It is within the Yong Loo Lin School of Medicine, National University of Singapore. NUS is Singapore's flagship university and a leading global university centered in Asia. We offer undergrad and postgrad programs and have a total population of over 1,000 students. Our research program covers the following: chronic illness and long-term care, women and child health care, patient safety and quality of care, geriatric care, and wellness. I hope that you can go to our website to learn more about our department and our research program, and we welcome all of you to collaborate with us in the future. Let me once again thank you for participating in this webinar, and I hope you have an enlightening one today.
Thank you, Prof. Emily, for your introduction to our education and research programs. To add to Prof. Emily's introduction, actually our master and PhD programs are open to both local and international students. So if you are interested in our program, you can always visit our school website to find out more information. Okay, now let's move to our today's session on the topic of nurse-led community care to promote healthy aging in Singapore. I will start by introducing our three speakers and also give a very brief overview of our local community-based initiatives in promoting healthy aging. Throughout the whole session, you can always raise your queries at any time with the Q&A function at the bottom of your screen. Okay, the panel will answer your questions at the end of the session. Okay, so our first speaker, Dr. Seah Betsy. Betsy is the research fellow of NUS Nursing, and her research interests actually focus on using cellulogenic related positive concepts, for example, sense of coherence and purpose in life as health-oriented approaches for people to live life fully. Our second speaker, Dr. Vivien. Vivien is our assistant professor, and her research interests focus on four major areas: chronic disease management for older adults and caregivers, intergeneration programs to promote healthy aging in the community, professional development of healthcare workforce, and nursing education. Our third speaker, Dr. Wentao. Wentao is our senior lecturer, and actually Wentao is also an advanced practice nurse in Singapore. So being at APN, Wentao is particularly interested in designing community APN initiative caring services for neurodisabled patients. So later, our three speakers will share with us about their research projects, okay? Okay, now I just would like to have a very brief introduction on the development of community-based initiatives for older adults in Singapore. So actually, the same as many other developed countries, Singapore is also facing the challenge of aging population with nearly 20% of residents currently 65 years or above. It is estimated that by 2030, about 1 in 4 residents would be 65 years or older. With aging population, more and more people are suffering from chronic illness, for example, cancer, heart disease, diabetes, and dementia. So chronic diseases actually account for 2/3 of total deaths in Singapore, and chronic diseases are likely to continue becoming the prominent disease burden in Singapore. Singaporeans are also living longer. So a resident aged 65 today is expected to live up to 85.3 years, and compared actually 78.8 years in 1980. So Singapore actually becomes one of the longevity countries in the world. Not surprisingly, old age support ratio has been falling dramatically for the past years. So currently, actually, less than 4 working adults need to support one senior. And in 2030, there will be only 2 working adults to support one senior. So in addition, there is notable increase in senior-only households. So according to the Department of Statistics Singapore, the number of both couple-based and single-based seniors has been increased dramatically for the past 10 years. So due to the aging population, the social and healthcare needs are changing. In terms of the social needs, there are greater need for social support and also greater risk of social isolation. Whereas for healthcare needs, there are more hospital visits and longer hospital stays, as well as more chronic and long-term care needs. So all these needs are also getting more intertwined, and all this actually has been put huge challenge to our healthcare system. So our aim is to enable seniors to age in place. For the past years, there have been community-based projects being initiated to keep our seniors healthy, active, and safe, and to provide them access to quality and affordable care. So to keep our seniors healthy, active, and safe, the country has been working very hard towards to provide senior-friendly housing and towns and build senior-friendly communities across the country. So I think for the local audience, you may have heard this People's Association's awareness program. So this program actually was launched in 2008, and it has been rolled out to all 87 constituencies at the end of 2012. So this program actually includes regular health screening, physical exercise programs, and social interest groups to keep our seniors physically, mentally, and socially active. In 2007, Singapore's government also set up Council for Third Age, C3A, to help our seniors to achieve a better quality of life and to promote active aging through funding programs in lifelong learning and senior volunteerism. To provide senior-friendly housing and towns, Singapore government has also implemented many initiatives, which include senior-friendly housing. I think you have heard these studio apartments, and also multi-generation family-friendly housing, as well as options for seniors to monetize housing assets. In addition, our seniors actually are provided with up to 95% subsidy for their home renovation to make it more senior-friendly. In Singapore, you can always see senior-friendly road areas in places with high concentration of seniors. There are also projects being put in place to actually enhance the barrier-free access in the community. So the government actually has been put great effort and resources to build senior-friendly communities across the country to keep our seniors healthy and active, to make them as part of the closely knit community, and to make them be able to live independently and confidently. So there have been also initiatives to improve the accessibility and enhance quality and affordable healthcare to our seniors. Over the past years, the healthcare capacity has been expanded with more new acute and community hospitals built up. Actually, by the end of 2020, over 10,000 acute community hospitals and nursing beds were added, and there will be new hospitals established in the upcoming years. Similarly, there has been expanding home and community care with nursing home as backup. So if you look at the capacity for community care, home care, and as well as nursing home, this has been actually increased dramatically for the past 10 years. So to meet the needs of aging population, we do need to actually reorganize our system to deliver patient-centric care through the integration of services and process. So with primary, acute, intermediate, and long-term care working together to provide best care to our seniors. Our current suite of healthcare services needs to meet diverse needs of seniors and caregivers at home. We have built actually very comprehensive services from transitional care to home care to provide holistic care to our seniors. And in Singapore, to provide affordable care to our seniors, there are many actually healthcare subsidies catered to our seniors. For example, making outpatient care more affordable, we have these means-tested subsidies at private GP clinics, also Medisave for chronic illness. Making long-term care more affordable, we also have these enhanced long-term care subsidies and enhanced seniors mobility fund to subsidize transport and consumables for more home and community care patients. And we also have this elder sheet to provide long-term financial protection for our seniors. Okay, don't forget our pioneers. We also have special, costs for our pioneers to cover their medical costs, and MediShield Life to cover more costs actually for our population. So with all these initiatives, we actually aim to make Singapore a nation for all ages, where seniors can age in place and successfully. Okay, we all know that nurses actually play a very important role in community care. So today, we are very honored to have our three speakers, Dr. Betsy, Dr. Vivien, and Dr. Wentao, to share with us about their nurse-led community project for older adults. So Betsy is going to share with us about her PhD project on the development and the pilot testing of a health resource program for the senior-only household. And Vivien is going to share with us about the project on a community-based e-health program for older adults living with chronic illness. And Wentao actually is also going to share with us her experiences as an APN, actually how to build an APN-driven community initiative for older adults with Parkinson's disease. Okay, without further ado, I will hand over to our first speaker, Betsy. Okay, Betsy, actually over to you.
A very good afternoon to all of you at the other side of the screen. Thank you for taking your time off today to attend this webinar. So Professor Wenru has provided an overview of Singapore's aging landscape, as well as some of the developments in the community care thus far. So I'm going to share about this community-based research initiative that we embarked on back in 2016. And as shared by Professor Wenru, this was also my PhD study. So first, let me introduce my research team. So there's, of course, Professor Wenru, who is also my PhD supervisor, Professor Emily Ang, Professor Gil from Norwegian University of Science and Technology, Associate Professor Srini from Department of Social Work, Associate Professor Yanika from NUS Nursing, as well as Ms. Jean Fon from Boon Lay Constituency. So back in 2015, and as many of you would be familiar with, as part of the Ministry of Health's effort to make Singapore an inclusive society, a 3 billion action plan for successful aging was being rolled out. And this action plan comprised of more than 70 initiatives across 12 diverse aspects such as health and wellness, learning, housing, retirement adequacy, and so on and so forth. So despite various communicative efforts in reaching out to the older adults, the understanding of the intent and the usage of all these multiplex initiatives can be quite overwhelming for these folks. So And this is especially so because most of our elderly of that generation in Singapore, they receive little years of education, and some of them may not be IT savvy or resourceful in searching for these resources. As such, the integration of knowledge on these resources are needed to better utilize them and to allow our older adults to apply to their own context of health. So like many Asian countries, feminism and filial piety are valued virtues in Singapore. So the responsibilities in providing care and support for seniors lie predominantly on children. And as shared by Professor Wenru, she mentioned that there has been a notable increase in the number of senior-only households aged 65 years, with individuals aged 65 years and above. And these households are couple-based households or individuals who stay alone only. And studies have shown that they are more vulnerable compared to seniors living with children, as they receive lesser support from their family members. However, they are more independent. And that being said, they are also more likely to seek alternative resources in the community and government resources for support. International studies have shown that they are more likely to have poorer health outcomes and adopt less health promotive behaviors and preventive care services. So with the super age population in time to come, it is also important to maintain or even improve the health of our seniors by upstream measures on health promotion. However, there is a lack of health promotion intervention studies for this vulnerable population, particularly on the integration of health resources, as well as all this information. So there's also limited theory-based and multidimensional health promotion initiatives for older adults. So this actually led us to embark on this study to develop a theory-based health resource program titled Cellulogenic Healthy Aging Program Embracement for older adults residing in senior-only households. And this study actually comprised of 4 key processes. First, which is the literature review to identify the scope of intervention content. And we also use the cellulogenic theory as a theoretical framework as a basis. We have the conduct of qualitative study to understand older adults' perspective towards healthy aging, as well as to identify their health needs. And lastly, the conduct of a pilot trial to test the feasibility of an intervention. So we first delve into the literature to understand older adults' perceptions towards the contributing factors of healthy aging, so that as care professionals, we can actually strategize and align health interventions to facilitate this pursuit. And these factors are having physical and mental health, being socially connected and supported, being active and committed to healthy behaviors, being safe and secure, being independent, being spiritual and religious, as well as having positive and optimistic outlook. So that this older adults' perspective of healthy aging actually spread across multiple aspects of later life. And it includes a bio, psycho, social, and spiritual health. And therefore, this actually leads us to conduct a systematic review on to find out what are the multidimensional healthy aging interventions that address the physical, mental, and social health of independent community dwelling older adults. So we wanted to find out what are the content of these interventions. And this content were being categorized as follows. Firstly, aging attitudes and beliefs, managing individuals' health, physical environment, social cultural interaction and commitment, as well as social structural health. So you realize that they actually cover a range of person-focused to environment-focused topics. And the number here that you see at the side here, they refer to the number of studies mentioned. So for example, for physical activity, 11 out of 15 studies actually covered physical activity in their health intervention. And most of these studies actually focus on topics such as physical activity, cognitive health, healthy eating. And only very few of these studies actually focus on environment-focused topics, which are also important to aging well. So moving from our literature review to the cellulogenic theory, which underpins the theoretical frame of this study, I'll introduce to you what is the term cellulogenesis. So the term cellulogenesis refers to the origin of health. And this theory focuses on factors that create health. So it takes on the view that health is actually a continuum and there is no dichotomy between health and illness. So it distincts from the traditional biomedical model approach on pathogenesis, whereby we treat people by their disease and manage their risk factors. So essentially, the cellulogenic perspective looks at the story of a person holistically beyond the disease. It looks at the strengths and assets of a person. It assumes that stresses in life are actually health promoting and well-being is actually being generated through active adaptation. So this stress resource theory has two key concepts. Firstly, generalized resistant resources. And generalized resistant resources refers to any characteristic that helps one to cope with stresses. And examples of these resources could be resilience, money, knowledge, as well as social support. The second concept of this theory would be sense of coherence, and this is actually a psychological concept. It is an orientation in which how a person perceives life as comprehensible, manageable, and meaningful. So using this framework, we want to strengthen the sense of coherence of older adults to use resources to cope with stresses of healthy aging. So for now, I would like you to pay attention to these three concepts: stresses, sense of coherence, and resources. So to understand the context of healthy aging and resource mobilization among older adults residing in senior-only households, we conducted a qualitative study. And from this study, we wanted to find out what are the stresses of healthy aging, which are listed as follows here, as well as we want to find out how can we actually strengthen sense of coherence via these three components on comprehensibility, manageability, and meaningfulness. So for further information, you can actually refer to our publication as identified here. So in addition to this, we also wanted to find out what are the healthy aging resources that actually help these older adults to cope with stresses. So these resources, actually range from internal resource. For example, as you see here, past experiences, self-care knowledge, positive disposition, to social resources, friends, family, neighbors, and all the way to environment or community resources as identified here. So from there, we actually target on the three components of sense of coherence, and our intervention content focus on helping older adults to understand their health as well as the aging process so that they can actually take on proactive actions and reflect on their life experiences and embrace their lives at old age. So the SHAPE intervention is a health resource program that uses a multi-modal approach. It comprises of 12 weekly group sessions whereby participants can learn from each other through peer learning and promote social interaction. So each week actually covers a specific topic. And there were at least 2 home visits to actually provide personalized care and to allow older adults to set their own health goals. Lastly, we also have a SHAPE resource book, and this is actually a consolidative book that covers 7 different chapters on resource information, which I'll elaborate in a short while. So apart from using sense of coherence to target on the intervention content, we also applied various cellulogenic principles in the intervention. So one example is actually to focus on the story of a person beyond the disease. So what we do is we have a short life review using the life ruler, whereby participants actually mark down their significant moments in life. And this helps them to reflect on their life thus far. And allow them to actually make sense of the old age process. So this is an example being done by our participant during the pilot study. So this is another example of how we actually apply the cellulogenic concept, which is to get older adults to be aware of their own social resources. So we get them to draw their own social eco map. And in fact, social eco map are being used by social workers when they actually develop care plans. So this is also another example that was being drawn by our participant here. The SHAPE intervention adopts an asset-based approach. An example would be how we utilize the resource book. So this resource book actually provides a wide range of information on resources which older adults can tap on. And for example, it includes information on self-care, health knowledge to existing healthcare schemes, or even policies which the older adults can use themselves, as well as information on advanced care planning, end of life, etc. And it also include like hotlines, okay, as well as websites for them to access if let's say they need further information just by scanning the QR code here. So basically the various aging assets that was being identified through the qualitative study were being included in this resource book. So another example would be active adaptation, which is actually to create experiences to allow the older adults to develop personal capacity for resourcefulness. So what we do is we get the older adult to take picture of their usual meal, and after the session on nutritious eating, we get them to prepare their own nutritious meal. During the group sessions, we also ran physical exercises. These exercises were especially designed to increase functional movement of older adults. And during the group activities, we use various pedagogical strategies to tailor to older adults' learning needs and abilities. So for example, we had many group discussions as seen here, as well as small classroom activities. So this is an example of how we get the older adults to identify signs and symptoms of heart attack, sepsis, stroke. And we also use case studies as well to illustrate, to actually go through certain concepts. So the home visits are actually the core of the SHAPE intervention. They are personal reflective sessions to put together existing and learned resources into the context of the older adult. And so it uses a very systematic approach of having the seniors to fill up a senior information sheet. From there, they identify their own individual health needs and set their own health goals. So what we do is we establish a goal contract with the older adults. We get them to write down their goals, the action plan, and then they sign on this contract. Examples of the goals that they set would be, for example, it could be related to family and friends. Okay, it could be related to having to perform physical activity, or even to actually look into end-of-life matters or death, such as like signing AMD, making a will, initiating discussions with their children, and so on. So a 2-arm pilot randomized control trial was being conducted, and we had 2 runs of the intervention. 16 older adults were being randomized into the intervention, while 18 into the control group. And these older adults were at least, there's a typo, 60 years old and above, living alone or with another older adult. And they must be able to converse in Mandarin because our sessions were being conducted in Mandarin. So our pilot study had 3 aims. In interest of time, we'll look into 2 of them, which is to examine its acceptability towards the SHAPE intervention in terms of perceived satisfaction, as well as to examine potential effects of the SHAPE intervention on the older adults, particularly on the outcome measures on sense of coherence, self-efficacy, quality of life, and health-promoting lifestyle behaviors. So to determine acceptability of the SHAPE intervention, participants' satisfaction was being assessed using the evaluation form that's being developed by our research team. So it comprises of 13 statements on the intervention itself, as well as 4 open-ended questions. So what you see on the left-hand side here, these are the statements, and the participants are supposed to grade accordingly, strongly agree to strongly disagree. So most participants strongly agreed that the program was useful, as denoted by the orange bar, and they strongly agreed that the home visits motivated them to take actions for their own health, and that the resource book, the information in the resource book is useful. So content analysis was being used to analyze the qualitative data collected from open-ended questions found in the 2 evaluation form. And this data was being categorized into 2 teams, particularly program experience and usefulness of program. So the participants expressed that they had a positive, enjoyable experience. Most of them agreed that the intervention was tailored for seniors. However, a few of them identified that several misfit of activities for seniors with lower physical function, abilities, and literacy levels. So participants also indicated that they gained health knowledge, experienced both cognitive and physical benefits, and they felt activated. A number of them mentioned that they put the knowledge learned into use. So as this is a pilot study, we actually employed a very small sample size, and we are very mindful that our study lacks power significance. Nonetheless, we wanted to find out what are the potential effects of the shape intervention, and therefore we collected some data, and this is as follows. Okay, so we conducted a PET-T test analysis to determine score differences between the pre and post test for within the intervention group and within the control group. And what we see here is, although there is an increase in overall sense of coherence scores in the intervention group, there's no significant difference. Okay. However, we observe significant differences, particularly in the health-promoting lifestyle behaviors, especially the total scores, health responsibility, physical activity, nutrition, spiritual growth, as well as stress management. So note that we also ran an ANOVA analysis. However, there was no significant differences observed in all the outcomes between the intervention group and control group, and this likely because of our lack of power significance for the study. So all in all, the SHAPE program is a potentially useful and enjoyable health resource program tailored to older adults' needs. Due to our small sample size, further empirical work is needed to evaluate the effectiveness of this program. And we are also in the process of developing cultural and validating more culturally appropriate cellulogenic-based outcome measures to evaluate future interventions. So I've now come to the end of my presentation. Thank you for your kind attention. We'll have our Q&A after all our speakers have speak. Thank you.
Thank you, Betsy. Thanks for your wonderful presentation. Maybe just a quick summary of Betsy's study. So as mentioned by Betsy, actually, you can see there is a notable increasing number of elderly living alone in Singapore, and this group of elderly is more vulnerable. However, navigation through health resources to promote physical, psychological, and social health can be confusing for many older adults, especially those elderly who live in senior-only households. So they may need more help. So Dr. Betsy actually shared with us about her PhD study on the development of a theory-based multidimensional health resource program for older adults residing in senior-only households. And this is actually a 12-week intervention titled Cellulogenic Healthy Aging Program Embracement, SHAPE for short. So this program aims to identify, equip, and strengthen both existing and new resources for these older adults to age healthily and purposefully. So you may see actually the team has already published several papers from this project. There will be more papers coming up from our pilot result. So if you are interested in this program, you can always actually try to find those papers and to get more information. Okay, again, thanks, Betsy. Okay, now I would like to invite our second speaker, Dr. Vivien. Vivien is going to share with us about her startup project. Okay, Vivien, please.
Hello, hi. Thank you, Prof. Wenru, for the kind introduction. Good afternoon, everyone, and really happy to see so many of you joining the seminar today. Yeah, so I'm going to share with you the project that currently we're working on, which is a community-based e-health program for older adults, who are living with chronic illnesses. Yeah, so the focus of the presentation today is mainly on how we develop the program, yeah, and also the pilot testing. Right. I think from the sharing by Betsy and Prof. Wenru earlier on, we have a good understanding about the stats information on the aging population. So with that background, we are aware that most of these older adults are living in a community setting, and they are having not just one, most of the time multiple chronic diseases, right? So currently, multiple healthcare settings do conduct health education program. However, it consists a lot of time, effort, and also manpower. So with that background, and also, our senior populations are actually getting more and more well-versed, or at least get exposure with the smart devices or IT platform. So we want to tap on those platforms to enhance or even empower our seniors, so they could better manage their chronic diseases, and improve their health literacy at the same time. Right. So the purpose of the project, we would like to empower the community-dwelling older adults to lead meaningful and fulfilled lives with the use of technology, and also to develop partnership with the community settings to promote, health aspects for the seniors. Right, so we actually adopted a self and family management framework as a conceptual framework for this project. Yeah, so from on the left bar, you could see that there's a lot of risk and protective factors, be it from the personal health status, individual factors, family factors, or environmental context, and this could somehow affect how we manage our health conditions. So we hope, through the project, we could then enhance or promote some of those factors to then encourage or empower the seniors to better manage or control their diseases. So then, it can promote their quality of life, medication adherence, family functioning, or even towards better utilize of community resources that's available for them. Yeah, so the project actually adopted a 3-step formative design of the intervention. Yeah, so in phase 1, front-end analysis, we actually conducted focus group discussions to find out what are the needs of the seniors in terms of, how we could better support them to manage their condition, and how acceptable they are in terms of e-health. Yeah, and of course, literature review give us a very comprehensive background. So from there, we actually identify the needs of older adults regarding the e-health, and then formalize our initial design ideas. In stage 2, we develop the preliminary design of the intervention. And in phase 3, we then allow a group of seniors to use the program and then collect the feedback. So from there, we revise and refine the program. Yeah, so from the initial design, we can understand from literature that, I think Betsy also mentioned earlier that this group of seniors, their literacy level are not that high. Most of them are in primary school educated or even lower. Yeah, so if we give them, papers or literatures or articles to read, may not be very feasible. And from the focus group, we can understand that they prefer watch videos. Yeah, it could be attractive to them. So then the research team have reviewed and feel that, we could tap on the video platform then to provide or to deliver the contents through the video. So you could see that, we focus on 3 major chronic diseases: hypertension, hyperlipidemia, and diabetes. Because these are the 3 most common chronic conditions among older adults. And besides that, we also provide information on exercise, diet, lifestyle modification, and also brain health. And we hope to encourage them to be physically active and practice mindfulness. Yeah, so with that initial design ideas, we actually form a panel of content experts, and then we invite the experts to review the contents, based on how relevant is the content, how appropriate it is, and how comprehensive from a scale of 1 to 4. So the panel consists of 2 nurse clinicians, 2 geriatric physicians, 1 physiotherapist, 1 dietitian, and 1 pharmacist. Yeah, so from the first results of content validity testing, the skill content validity index is 1. And then for those items or contents who was rated below 3, we have revised them and sent them for second round of content validity testing to the panel. And based on the second round, the results showing that the SCVI and the item CVI has achieved 1. Yeah, so that is an indication that the program has valid contents and in terms of the relevancy, appropriateness, and comprehensiveness. So then that gives us the confidence that we can proceed with the program. So if you look at the community-based e-health program, besides the health education topics, you also provide a platform for the seniors to enter their blood pressure reading, sugar level reading, and then they could monitor the trend over a period of time. And if the range is beyond the normal range, and then the system could send them an alert message and also alert them, advise them on what to do. Yeah. Okay, so how do we plan the delivery? We know that if we just solely based on e-health model, it may not work well for this group of elderly because they still prefer certain level of interpersonal communication. So we, in fact, we use a blended approach that the entire program consists of face-to-face group therapy, e-health platform, and also virtual follow-up. Yeah, so this is the outline of the program. For the pilot test, we actually did an 8-week intervention. So every week we had a face-to-face group session and follow up with an e-health program to reach out to them. You could see that for every session we start with exercise and end up with mindfulness practice. So that is to encourage them to form the habit of being physically active and learn skills to stay calm and find ways to learn to relax. Yeah. So for every session, we have a focus in the topic. So for example, session 1, we focus more on hypertension as management. Week 2 is more on the management of cholesterol level. Week 3 is more on diabetes. Week 4 is more on healthy diet and what are the healthy choices they could make. Week 5, we then move on more towards brain health to teach them what are the subtle signs and symptoms of cognitive impairment, and then how do they self-monitor their cognitive status. So in week 7, we focus more on medication adherence and how to build up their social support. So in week 8, we focus more on those lifestyle modifications like stress management, weight management. Yeah, so this is a excuse me, this is a Care for Senior app that our team has developed. So if you look at the center, this is the main page. Once they log in, they will be able to choose 4 major modules. So once they click on the daily care, you bring them to the page whereby they can enter their blood pressure reading, sugar level reading, and they also could see the trend over the past week all the way to 90 days. And that gives them very good self-awareness to remind them about their health status. Yeah, in the exercise module, we provide step-by-step instruction videos to teach them how to do exercise and encourage them to be physically active. Even under the current pandemic situation, they may not be able to go out to do exercise. Yeah, in the quiz function, the apps will actually post 3 quiz questions every day, and the quiz contents are all related to the health library. And you could see that there's a leaderboard page here, which will actually display the higher score, ranking to the lower score. So that serves as a motivational system to encourage them to participate more in quiz. Yeah. So under the profile page, they could see their own score in terms of viewing the videos in the health library, entering the recording in the daily care, exercise, and so on. Yeah, so in the health library, we actually utilize videos to deliver the healthcare information. So to bring the story closer to them, we actually engage an elderly couple, a story between them, Mr. Tan and Mrs. Tan. So both of them have chronic diseases. So it's a series of conversation between them. How do they encourage and support each other to manage their condition? Yeah. I have a short video clips here.
Hey, why do you look so distressed?
Hi, I just talked to the community nurse, and he said my diabetic condition is getting worse. I've been experiencing tingling sensations in my limbs, especially my foot. The nurse told me it's likely neuropathy, the damage of a nerve, and it's common in patients with uncontrolled diabetes.
Have you been monitoring your blood sugar level regularly? And have you been taking your medication on time? Neuropathy is not the only complication you might experience when your diabetic condition worsens. The doctor said that you may develop a diabetic eye, foot, kidney failure, and even cognitive decline. I think the worst is if you develop heart complications.
Yes, indeed. I'm afraid my diabetes will become that severe.
Don't worry. I can tell that you have been exercising and eating healthier lately. I will support you in eating a healthier diet and will exercise with you.
Yes, I will pay more attention to my health from now on. I will eat less sugar and carbohydrates and aim to exercise for at least 2.5 hours a week. Hopefully, I can lose weight too, which will prevent my condition from deteriorating faster. I'm going to measure my blood sugar level now.
Yeah, so this is a sample of the part of the e-health video that in the apps. Yeah, so for recruitment criteria, we are looking at older adults who are 55 and above, diagnosed with at least one of the 3 chronic conditions and able to commit to the e-health program. Yeah. Outcome measurements besides social and clinical outcomes, we also looking their cognitive status using MOCA and SDMT, their self-care ability, healthy aging practice, health literacy level, and how is their empowerment level and social support system. So this is the pilot test that we have run, just completed in April. Yeah, so and you can see this is at the beginning, we started with exercise session, and at the end, we end up with mindfulness practice. We deliver the contents, and we help each of the elderly to install the apps, Care for Senior app, into their smart devices. And throughout the session, we could observe a lot of peer learning and peer support happening. They are teaching each other how to maneuver over the app. Yeah, so this is outcome from the pilot test. In total, we had about 8 participants. The main age is 74, so quite an advanced age group. Yeah, majority are female. Yeah, and most of them are retired. And staying in public housing system. So most of them are actually mobile and independent. So and you can see that they are having more than one, in fact at least 2 or even 3 chronic conditions. Yeah. So from the pre and post intervention, we could see that the HbA1c scoring has been lower. Yeah. And then for the self-care instrument in the subdomain of maintenance, monitoring, management, that's increased in post-intervention score, despite that the results are not statistically significant, right? Same as empowerment and social and healthy aging practice, that's increased in score post-intervention. However, due to the small sample size, the results are not statistically significant. Yeah, but the pilot tests do give us a very comprehensive background information on the contents and also test it out for all the operational issues. Yeah, so besides that, we also collected user feedback on the Care for Senior apps. And majority of the participants feel that the apps is easy to navigate around, and they do appreciate the quality of information that delivered in the app. Yeah, so in fact, they also provide some simple qualitative comments like, they enjoy the exercise video, they like the health records, which allow them to key in their BP reading. They enjoy the character of Mr. and Mrs. Tan, yeah, in the video. So moving on, in our next phase, we plan to conduct a large-scale study which consists of both experimental and control group. So for the participants in the control group, in the experimental group, we will then invite them for focus group discussion to explore more on their experiences in using the eHealth program. So the project has been ongoing for 1 year, and I believe it's similar with colleagues who conducted research for elderly in the community setting. There's multiple challenges that we faced as a team. Yeah, so first of all, there are multiple partners that we need to liaise with. Yeah, so it takes a lot of time and patience. Yeah, ethical board application is long process. For program development, also the team has to brainstorm, come up with initial ideas, and then engage the content experts in reviewing the contents. Yeah. So for recruitment of participants, I think for this group of seniors, maybe because of the age and educational background, research is quite foreign language to them. So their initial response when we approach them is, "Are you going to do experiment on me?" Yeah, so it takes a lot of time and effort to explain to them about the program. And the program has been ongoing in multiple centers, so we need to liaise with many different stakeholders. Yeah. And for the data collection process also, because for the instruments that we use, though it is validated and suitable for seniors, perhaps because of their literacy level, we need to be very patient and explain to them item by item. Yeah. So we would like to acknowledge the following partners. This project is in collaboration with Changi General Hospital Community Nursing, and we would really appreciate the support by staff from senior activity centers. And the project is funded by NUS Startup Grant. Yeah, thank you so much.
Okay, thanks for Vivien's sharing of her wonderful study and some take-home messages from Vivien's study. So we know that nurses play important roles in health promotion for older adults, especially in the self-management of chronic illnesses. So health education is an essential part of self-management intervention, and psychosocial approach is an effective method to increase self-management capabilities for older adults. So we know that with rapid development in technology, it's feasible to utilize the IT platform to enhance self-management capabilities for older adults. I don't think that, for those older people, there is no way that we can use any technology. That's not the case. We have been doing so many community projects, I think also for Betsy's study. So if you really teach them how to use the smartphone, they really learn, they can actually use it, okay? And Dr. Vivien and also her team actually developed this community-based eHealth program, and they actually apply an eHealth platform, and also face-to-face small group health education, as well as virtual follow-up to promote self-management capabilities for community developing older adults with chronic illness. We actually look forward to the final outcomes of the large-scale study. Thanks, Vivien. Okay, now we move to the last session. Okay, I would like to invite our last but not least, the third speaker, Dr. Wentao, to share with us about her project. Wentao, please, over to you.
Hello, good afternoon, everyone. Thanks, Wenru, for your kind introduction. And good afternoon, friends and colleagues one screen away. Nice to see you all. Although I cannot see your face, many of you are here to support us. Thanks. Wenru have shared some of the background for elderly, and Betsy have shared her study. Vivien have shared how technology actually enhance the self-care for elderly people. So me, Wentao, an advanced practice nurse, currently working one day at National Neuroscience Institute, as well as Master of Nursing Program Director at Alice Lee Center for Nursing Study, training advanced practice nurse. So my focus for today is I'm going to share with all of you an advanced practice nurse-driven community initiative for elder adults with Parkinson's disease. Let us just go through this all together. So this is my today's outline. I will start with overview of Parkinson's disease in Singapore. Then I will move on to existing community care models for patients with Parkinson's disease and challenges to the existing community care for patients with Parkinson's disease, and some of the improvement measures we have initiated as a team, and also the ideal community care models for patients with Parkinson's disease patients. So this is the article in 2019. It stated, actually in Singapore, our population is aging, and also the life expectation is increasing, and the number of Parkinson's disease patients actually expected to increase by 2030. I think this is not a new things to us. This is also comparable to the international healthcare issues. Now, of course, for come to the Parkinson's disease, all of us know that it's not a curable disease. But however, currently, we have a lot of medication treatment as well as a multidisciplinary approach to care for patients with Parkinson's disease. So some recall together for the Parkinson's disease, it is a chronic neurodegenerative disease that affects the central nervous system, affects the motor nervous system, but also accompanied by a lot of non-motor symptoms as well. The main treatment for now is we use levodopa and dopamine agonists, a lot of medication for treatment. But however, more and more deep brain stimulation is gradually become widely used at early stage for the Parkinson patient, if not well controlled by the medication. So Parkinson's disease is a very high economic burden disease. In 2019, Yang and her colleagues in US have done a study. The total cost to individual families and governments is about 51.9 billion per year. And direct medical care is about 25.4 billion, and non-medical cost is about 26.5 billion. So non-medical cost refers to missed work, some of the patient lost their wages, and also the healthcare provider need to take care of the patient and do not go to work. So this is the trajectory of the Parkinson patients' experience when the time before they develop, actual diagnose the disease till the end of stage. You can see it's very complicated. Not only affect their motor function, which is the upper darker green portion, and also significantly affect their non-motor domain of the function. So to treat the Parkinson's disease is rather complex. And there are 5 stages of development for the Parkinson's disease. As you know, one side is being affected, that is stage 1, two sides is being affected, that move to the stage 3. A lot of time, when the time patient actually become more and more complex, which they step into stage 3. When the time the balancing is being affected, the function is being affected. Moving down the road, stage 4 and stage 5, a lot of them, they need some walking and standing device. And majority of stage 5 patients, they are wheelchair bound and bedridden. So it's rather complex to treat Parkinson patients. So if you can recall Dr. Betsy's lecture, she has mentioned the psychosocial factors actually affect the patient's health, which that is also applies to the Parkinson patient. So by looking at this chart, a lot of time we are only focusing on this 20%, which is medical care. It's somehow we neglect the other 80%, which is health behavior, physical, environmental, and social economic factors to the patient's condition. That's why I think Betsy and Vivien's research are very valuable moving forward to support patients in the community. So for Parkinson patient disease, which I'm not so sure why this, okay. So for Parkinson disease, actually, there's many studies have stated it's not only just affect the patient, also affect the care provider. So you can see in the left side, Hamland and her team have studied how the Parkinson disease affect the patient's daily activity, their identity, as well as their physical, mental health. The last part actually is the disease affect the ability for the patient to resist psychological pressure as well as the social participants. Over the right side is our local study. Dr. Tan and her team have studied our local caregivers' stress strain level, and the study showed a lot of caregivers are overstrained when the time they take care of the Parkinson patient. This is very comparable to the national study as well. So bring everybody back to share about some of the community care models which we have implemented in, at National Neuroscience Institute. In 2007, this integrated community care program was established. It's led by the advanced practice nurse and the group of nurse clinicians, supported by the Parkinson disease physicians. The aim is to improve patients' quality of life and disease management by filling the gaps in the care, particularly in the community. So recall about community care, which is not actually a new model. In about 1930s to 1950s, majority of the care actually happened at the home or the community. But in 1970s to 1990s, because the diagnostic tests become more advanced, the transportation become more advanced, there's many more medical centers have been built. That's why community care is not so popular and decreased. But in early 21st century, medical expenses are increasing. Medical system are overwhelmed in the hospital. So physical community care actually come back to as a model, which we see is the new model. In fact, it's not new. So come back again. And in the recent pandemic, due to the reduce of the physical hospital visit and also the limitations for patients to go back to the hospital seek for treatment, I think the advanced technology enhancement, so community care will be there and stay to support patients, particularly for Parkinson patients in the community. So for NNI patient, for NNI ICCP care program, our populations are rather patient discharged from the hospital and to go back to the home. And also some patient actually diagnosed disease and did not admit to the hospital, but went to the hospital to seek for the specialized consult. But however, they stay at home for the continuous treatment. We are targeting on this group of patients. So they stay at home, either self-care or actually care by the family, or actually they do have some other form of home care and day rehab or day care. So our population are this group of patients. They are at their own home. So we will go to their home to do a set of assessment. We will obtain informations to look at their motor and non-motor aspect which affect their daily living. And we will perform certain physical examination or neuromotor examination, use UPDRS. And we also obtain informations for how is the medication effects and complications, and whether the patient compliance to the medication, as well as we assess whether their chronic disease will be, are well managed at home as well. On top of that, we assess the patient family care environment and the potential hidden dangers. We assess the caregiver's competency, physical and mental well-being. We assess the effect of disease, the effects of the disease progression, whether from one stage to another stage. So overall, you can see we focus on the patient's care needs, as well as we focus on caregivers' needs. So of course, after do the assessment, we need to give the relevant intervention. We develop and implement preventive care plans, because a lot of time, the issues may not be happen when the time we visit the patient, it's rather after that. So we develop some preventive care plans and educate the family members and tell them how to do. And we review their medications and to adjust the medications based on the assessment, and we stop some unnecessary medications by discuss with the primary physicians. On top of that, we educate to enable patients and caregivers to detect the abnormal changes and ways to seek for immediate help. Where do they go for help for their problem? And establish therapeutic relationship to support them and to engage them as a care partner. For this part is to really hope to support the caregivers to reduce their care burden. On top of that, we also collaborate with the other community stakeholders to support the patient's care needs. So, but of course, doing the community care is never that easy. A lot of challenges because there are lack of structured collaboration with long-term care facilities and lack of collaboration with general practitioners in the community. There is no continuity of care sometimes. There's lack of support of the community medical financial structures. I think the government is looking into that at this moment. Of course, in addition, when the time we deliver the detailed actual care, there is lack of evidence-based community practice guidelines to support care implementation. Last but not least, lack of the Parkinson disease trainings and support for community care professionals. So by understanding all these issues, last year, the ICCP program have evolved. So we renamed this program, is called Neuroscience Network Integration in the Community Health. We collaborate with Sing Health Community Nursing from SGH site and Changi Hospital site. And also we work very closely with Home Nursing Foundation and also some of the nursing homes to looking after patients in the community. we developed structured communication referral channel. In the past, actually, there is no structured referral, but now we do have structured referral process. And also we developed some practice guidelines to guide the community nurses care for Parkinson patients. So our current focus is really train the community nurse to be competent. So we not only training them, just give them the knowledge. We hope they to be competent as a critical thinker with the knowledge and skills and decision-making ability. And we also train them to be good communicators, to good listeners, to understand what are the expectations from the family. We tell them they must be independent operators and problem solver to work with multiple stakeholders to solve the problems which encountered in the community and improve the patient's care. And on top of that, we also work with them together to adopt the new evidence-based practice to enhance, embrace technology for the care as well. And importantly, we also emphasize as a community nurse, they must be a fast reactor, fast react to the community care with the limited resources, cannot be everything, wait for resource to come, then change the care practice. So the most important is we hope our community partners actually work together with us and continue to become a continuous learner. So personalized community care is our goal, is our direction to go. It's really hope in the future our Parkinson patient can easily access the neuro care in the community. There is a single contact for them to reach and coordinate their care. Easy reach out to GPs and APNs in the community to manage the neuro medications and complications. Develop personalized care plans facilitated by the technology, and also continuous development, comprehensive care to support and develop innovative treatments for patients with Parkinson's disease. So this is a framework. Actually, ideally, there will be some central community Parkinson nurse to handle a group of patients, but work together with primary care physician, community allied health providers, community care centers. On top of that, work very closely with some social community services to support the patient's care. On top of that, this community Parkinson nurses will be work with specialized physicians very closely for either training and feedback to constantly develop new ways to treat for the Parkinson patients. So this is, we hope this will be, Singapore actually have many healthcare cluster. We hope all the cluster actually have the similar model to support the patient with Parkinson's disease. So there is a key contact person. There is a regional support from the allied health and social sector. There is a specialized center to support all these people, so to reach our patients in the community. So moving forward, we really hope to reach out to more community care services to develop an integrated care network. It's not only confined with SingHealth cluster, but rather the island-wide. On top of that, we need to embrace the technology and to adopt digital community PD care, and to see how to actually more easily to collect the data, understand our patients' disease development. So with this, actually, I hope there is some question. If there is any question, we can address face-to-face later on. So these are the articles actually back up all these frameworks, and we are moving forward too. So with this, thanks everyone. I really hope you can see how important the clinician and researchers work together to continuously develop the care in the community. Thanks.
Thank you, Wentao. Thanks for Wentao's wonderful presentation. Maybe just a very quick summary of Wentao's presentation. As shared by Wentao, that we can see that constantly improving the community care for patient with Parkinson's disease is important. Therefore, community care leaders do need to adopt a plan, do, study, and act improvement framework to constantly evaluate and improve the community care services. So successful community care requires patient and family participation. Highly skilled nurses are driven, and multi-stakeholders collaboration are also essential to ensure the successful community care. Okay, thank you, Wentao, for for your sharing. I believe that in this room we have the nurses actually from the community, the nurses from the hospitals, and also we have of course the students and also the faculty members. I hope that you can really learn something from our three speakers. Okay, so now I think we still have about 10 minutes for our Q&A. If you have any issues, any queries, please feel free to raise your questions using the Q&A function at the bottom of your screen. So actually, I see one question raised by Yiho. I think this is the wonderful question. I probably throw this question to Vivien. So Vivien, actually, Yiho raised this question. She said that with the current pandemic restrictions, how would the remaining research timeline or data collection method be adjusted to proceed with the study to get the more wide and dependable result? There are also variables that might have changed due to the pandemic, such as independent status, IT savvy level, lifestyle routine changes, and employment, etc. Vivien.
Yeah, thank you, Wenru. Yeah, so Chuyi, nice question. Yeah, so exactly that's the issues that we're facing now. Yeah, so in the situation of heightened alert, most of the community programs are put on hold. So in fact, for the past 1 month, we couldn't proceed with the intervention. So of course, but there are ongoing data that the team at least can work on. Yeah. So moving forward, we are actually in active discussion with our collaborators. So perhaps the way to go is using of technology. So in fact, the e-health program come at the right time. Yeah. So in fact, for the community nurse post, right? That's the nurses actually set up a station in the senior activity center to provide health screening and health counseling program for seniors with chronic diseases. Yeah, so in the past 1 month, the program also has been put on hold. Yeah, so in fact, our partners actually appreciate the e-health program that we are working on together, and we do hope that at least using the e-health platform, we can actually reach out to the seniors, even though they may not be able to come for face-to-face session. Yeah. So and also we are also actively exploring situation like if in the event that we really couldn't do any group session face-to-face, then at least we have the e-health program that we can install the app on their phone, reach out to them, and then perhaps we can continue to reach out to them on the virtual platform. Yeah, so of course, perhaps in terms of data collection, we can also tap on the resources like a Zoom session to conduct focus group and all that. Yeah, so in fact, a lot of changes are ongoing. We need to be very adaptable in the current pandemic situation.
Thank you, Vivien. Choyi, I hope that Vivien has already answered your question. Okay. Yeah, I think my next question maybe goes to Betsy. Basically, there is one question asked, what are the key concerns and daily living challenges of older adults living in a senior-only household?
Okay, thank you, Dr. Wenru, for the question. So for senior-only households, primarily based on our qualitative study, we find that, in fact, these older adults, they are pretty resourceful in their own ways, particularly because they have adapted to various life challenges. And however, when it comes to like when there are also moments whereby they require tangible support. So because if they live either alone or if not, they live either with their spouse only, when something happens, for example, when they suddenly fall down at home, or if let's say they require certain assistance with their handphone or technology, these are the moments whereby they require certain assistance. So through our qualitative study, through that identification of all this content, we actually address it in our SHAPE intervention. We equip them with certain skills and knowledge in terms of not so much of teaching them the content, but more of allow them to, okay, if let's say you encounter this problem, then what can you do? So it's more of like teaching them how to fish. So for example, when they were to fall at home, then what can they do? Okay, so first they have to check like, are they injured themselves? And then subsequently, who to contact help? Should they be heading to the GP, to the polyclinic, to the emergency department? So these are skills that were being shared during the intervention itself. So it is more of like how to help this group of older adults, to manage certain issues that arises suddenly at home, so that they will, in a way, feel more independent and more secure. So security is actually very important for older adults. Yeah, thank you, Dr. Wenru.
Thank you, Betsy. I think the next two questions are also for Vivien. Vivien, I think your home also raised a question, and I don't know, he or she asked, will your e-health program be conducted with the local dialects so that the more seniors can enjoy this platform?
Yeah, so in fact, we actually have two languages, both in English and Chinese. Yeah, so based on the experience so far, most of the seniors are able to speak, if not at least they could understand Mandarin. So because it's the program is delivered through video, so they can listen, they can understand, appreciate the contents in Mandarin platform. Yeah, so yes, yeah, but we also do have a group of seniors who are English speaking. Yeah, so in a way that having two versions of languages will benefit most of the seniors in our local setting. Yeah.
Another question is raised by Elena, and she actually asked that it seems like there are so many health apps in the healthcare system, like Health Hub, one NUHS Health Buddy, and she asked actually, is it possible to integrate the apps or further elaborate on the current system? You want to share some of your?
Yeah. I mean, it is definitely our end goal to integrate the multiple apps. But if you could see that currently the apps provided by different stakeholders actually have slightly different focus. Yeah. So I guess that's the intention that it perhaps focus on a specific group of participants. Yeah, but moving forward, I think it really takes a lot of initiative to bring multiple stakeholders to sit down together and discuss and collaborate. Yeah, so it is definitely a good suggestion, and we could look into this issue as a national initiative. Yeah, thank you.
Thanks, Vivien. So I think my next question goes to Wentao. Wentao, I think Xiao actually asked a very good question. I don't know whether you can see in the Q&A. It's actually quite long. So basically, she asked that in a generic elderly population who already have certain community resources support, at the same time, they could have certain diseases such as PD or cancer. how could we better consolidate ourselves and reduce duplication and achieve the same outcome of patient-centralized care?
Thanks for the question. I saw Xiao Jian actually post this question. I think this is very important. That's why we feel it's not really individual work. It should be collaborate between specialized center and the community care sector. So we should work together to develop structure to support the patient in the community. I'm not so sure Xiao Jian have mentioned about or cancer. I think cancer is should able to apply the same model, which cancer center can collaborate with the community sectors and to train a group of people. Actually, rather they are not so-called the cancer trained community nurse, but they are being trained by the specialized cancer nurses, so they can work together to reach out to the community patients in the community. I do not know that have answered Xiao Jian's question. So I think collaboration is very important. In addition, I feel to adapt or to actually embrace technology is another way we need to go towards too. Yeah.
Xiao Jian, I hope that Wentao has also answered your question. Okay. We try to keep our session within our 1.5 hours. So I probably have to end the session. I think you probably have more questions, but feel free to approach us, all the three speakers. I think they already put their emails actually at the end of their slides. And otherwise, you can always go to our school website to find out their email. So feel free to approach them if you have any further queries with regards to their project. Okay. With this, I think I thanks everyone again for your active participation. And we look forward to seeing you all guys actually in our next webinar. Okay. Our chat function will be open. You can also leave your comments and feedback on our webinar. We actually to help us to further improve our webinar. Thanks everyone. You all have a good day. Okay, stay safe and healthy. Thank you.
All up in my head, fear's got a hold of me. Pretend I'm not scared of who you call.